Good afternoon, and thank you for inviting me to the Transcatheter Heart Valve in Greece. Hopefully next year I can attend in person. I will speak today about mitral TEER in patients with cardiogenic shock. So let's start with a case. The first case, 74-year-old woman, presented to the emergency room with light arrival inferior ST elevation MI. She was coming from another hospital, then in which she was treated medically for 5 days, and then she was transferred to our hospital. On arrival, the patient was in severe tachypnea. Her blood pressure was low, 60/40. In fact, she was in cardiogenic shock. We can see here the X-ray showing pulmonary edema. She was transferred to the cath lab. We can see here diffuse multi-vessel disease with acute occlusion of the left circumflex artery. On echo that was performed immediately, we can see severe tethering of the leaflets. We can see the tethering of the posterior leaflet, but there is no papillary muscle rupture or no caudal rupture. And we can see here the jet of severe mitral regurgitation. In fact, she presented with acute, functional, severe mitral regurgitation due to late arrival inferior ST elevation MI. When we talk about acute mitral regurgitation, we're talking in general about three mechanisms. The first two are related to myocardial infarction. We have the dramatic approach of papillary muscle rupture. Patients often come in cardiogenic shock due to the rupture of the papillary muscle. We have a more subtle mechanism of rapid remodeling, like in this patient. The infarcted area is remodeled, causing tethering of the leaflets, an acute functional MR. And we have a different mechanism. Patients most of the time have degenerative mitral valve disease. They sometimes they rupture a cord, and then they come in decompensated state. So what is the cause of the decompensation in acute MR? Patients with acute MR, as we all know, have normal left atrial compliance. They have a small left atrium. Therefore, the smallest amount of regurgitant volume causes a rapid increase in the LA pressure. The LVDP is very high, and these patients get into pulmonary edema. In fact, there are two mechanisms. The mechanism of pulmonary edema due to the very high pressure, the LA pressure that goes very high immediately, which cause acute pulmonary edema. And on the other hand, we have a volume overload on the left ventricle. The stroke volume the forward stroke volume is decreased because most of the blood is going back to the left atrium, and those patients has a cardiogenic shock and signs of oliguria and other signs of hypoperfusion of vital organs. This is the mechanism of the acute MR, regardless of the etiology of the MR. The problem with acute severe MR that in many times the clinical picture is inconclusive. As we teach the students, the murmur is often soft and even may be absent because we know there is rapid equalization of the pressure between the LA and the LV. Relatively small amount of volume goes from the LV to the LA. There is equalization of the pressure, and therefore there is no additional flow to the left atrium. Similarly, the color Doppler that we see in the echo often underestimates the severity of the MR, in particular in patients with very high left atrial pressure. In addition, the quantitative evaluation of MR severity that sometimes we try to do, effective regurgitant orifice area, vena contracta, it is important to remember that they were validated only in chronic MR and not in acute cases. And in most cases, the usage of this quantification underestimates the acute severity of the mitral regurgitation. So how we can validate the acute severe MR, we often need several modalities. We have some echocardiographic features that are not related to flow and color. We can see tethering of the leaflets. We can find elevated pulmonary pressure. We see severe pulmonary pressure with no other explanation. We can see right ventricular dysfunction due to the rapid increase in the wedge pressure. An important feature is the pulmonic vein flow. It's very important to look at it. And if we see a deep reversal of the systolic vein in the pulmonic vein flow, we can suggest that there is a clinically significant mitral regurgitation. In addition, hemodynamic evaluation can also help if we see elevated wedge pressure with very high V wave. This both suggest that this patient has severe mitral regurgitation. And for example, if we see very high V wave and low blood pressure, so this patient is often have acute severe mitral regurgitation. Therefore, the clinical suspicion is required among patients with acute heart failure. If we don't have a good explanation for the acute heart failure, we must remember that acute MR is one of the causes in this condition. So what is the clinical spectrum of acute severe MR? In general, this is a classification that we published recently. We have the type 1 patients. Those patients are in the extremes. Patients in cardiogenic shock, the blood pressure is below 90, they're in pulmonary edema, there is signs of hypoperfusion reflected by high lactate levels. Those patients often required inotropic therapy and mechanical support, intra-aortic balloon, impeller, ECMO, and those patients often required an urgent mitral intervention. The type 2 is less severe, although those patients are pretty severe. They have refractory pulmonary edema, but the blood pressure is still maintained in normal range. Often they have signs of hypoperfusion, like low cardiac output, but normal lactate levels. These patients often require intravenous diuretic continuously, and they might require urgent mitral intervention. Less severe is a type 3. Those patients maintain their blood pressure. They might have some low cardiac output state. They have episodes of flash pulmonary edema. This is one of the signs of acute severe MR, episodes of flash pulmonary edema. They need IV diuretics, and we don't know exactly the role of valvular intervention. And there is the less severe conditions, the type 4. Most of those patients has probably a previous mitral disease and some remodeling of the left atrium. Therefore, they are not in decompensated heart failure, but those patients can be treated medically in most cases. So which patients are at risk to develop acute severe MR in the context of MI? Like the first patient that we presented, those patients often come with late arrival myocardial infarction. We have a suboptimal reperfusion, slow flow. Sometimes we don't get any flow at all. In many cases, there is involvement of the left circumflex artery, and in many cases, they have also multi-vessel coronary disease. So those patients often go into a heart team discussion. We know that medical therapy is an option, but those patients have very limited ability to tolerate the medical therapy. After a reduction and ACE inhibitors and stuff cannot tolerate it because of low blood pressure and a kidney injury that is common in those patients. Surgical mitral valve replacement is an option, but we know that those patients that get into the surgery in decompensated state are often have some issues in recovering from surgery, and there is an option of TEER or a mitral clip in order to try and fix the mitral valve and allow the recovery of the patients. So the data regarding urgent mitral clip in patients It came from a few years ago. This is one of the first publications of ours, and some centers in Europe, including the center in Athens, our friend Michael Christoheris and Kostas Pargias. In this registry, we first described the 20 cases of patients that were treated with urgent mitral clip due to severe acute functional MR after myocardial infarction. We see that the procedure was very successful in most cases, reducing the severity of the MR. You can see here the immediate impact of the left atrial V wave and the pulmonic vein. In fact, we can see during the procedure, the minute you grasp the leaflets, you can see a decrease in the LA pressure and increase in the systolic blood pressure, a very common phenomena in patients with acute MR. And those patients also, we can see here the recovery of them. They were able to recover the acute phase of the decompensated heart failure after the TEER procedure. This is the first publication, our publication, and a publication of our friend Rodrigo Estevez Louros, the IREMI trial. And after those publications, we decided to join and try to do a better registry. And before this registry, we also had a publication from the TVT data showing that patients that go for a mitral clip in cardiogenic shock, we can see the procedure was safe, the device success was high, and we can see that patients that had good result of the mitral clip procedure had better outcomes compared to patients that were not successfully treated with the clip, suggesting the importance of the TEER in those conditions. So, as I told you before, we had combined our registries, and we approached the hospitals and asked them to send us data on patients with acute MR that were treated or by clip or by surgery, or were treated by only medications. Those patients were recruited in 21 centers in Europe, North America, and Israel. All of them had at least +3 MR and heart failure after acute MR. And as I said, they were treated by surgery, clip, or by therapy. This is the patient characteristics. We can see the patient not very old. You can see that most of them came in CLIP 3 and more. Half of them were in cardiogenic shock. Many of them required inotropes, and many of them had intra-aortic balloon pump. The first findings that we see is that patients that were not treated by any mitral intervention, which means that were treated conservatively, had the worst outcomes. Almost 40% of them died in the first months, suggesting that waiting and treating with medication might not be a good solution in patients with acute severe MR. Next, we evaluated the comparison between patients that were treated by surgery and those that were treated by TEER. PMVR is TEER. And we can see here that although the procedure, the mitral clip and the surgery were both successful, more than 90% of the procedure were successful, patients with that were treated with surgery had very high complication rate. 1/3 of them had major complication, and this was translated into an increase in in-hospital mortality that was much higher compared to the TEER, suggesting that TEER in this condition might be a safer solution than surgery. And we were able to publish this findings in European Heart Journal a few years ago. As a result of this study and additional study, the recent guidelines of treating patients with acute MR, suggesting that after evaluation of the patient, of course, opening the artery if it's possible, considering mechanical support, then when you treat the mitral regurgitation, TEER is the first option, and surgery is advised only in selected patients in which TEER is not available or TEER is not safe to perform in those.
Thank you very much, Dr. Shuvy. We appreciate it, and thank you for allowing us to shave 2 or 3 minutes off the end of your video.
Sure.
Because all of our audience here and our audience online, we're more excited to have you with us for the discussion. Everybody likes the live interaction. I think everything that you showed us was groundbreaking. If you would be so kind as to remain connected with us, we have 1 lecture remaining, and at the end we've asked all of our speakers to just have a few minutes of patience, and Dr. Pereas will coordinate a lively discussion, but we just needed to make sure that we leave enough time for that discussion to be respectful to the next session. Thanks so much, Dr. Shuvy.